Hi everyone, and welcome to the latest webinar from Zoe. How does COVID affect children? I'm Professor Tim Spector, lead scientist of the Zoe COVID study and Professor of Epidemiology at King's College London. And today I'm joined by two experts, Professor Emma Duncan, Professor of Clinical Endocrinology at King's, and Dr. Michael Absood, who's a consultant in pediatric neurodisability and also a reader in the Department of Women's and Children's Health at King's. So welcome both of you, and thank you everyone for submitting your questions. We look forward to some great answers and discussing this topic about exactly how COVID affects children, which is, I think, a topic that's not been in the news nearly enough, and many people have their concerns. Now, with kids in the UK heading back to the classroom, I'm sure we have lots of parents watching today for some clarity, and we'll be looking at, can children get serious COVID? Can they get so-called long COVID? And really the important question in the news at the moment is, should we be vaccinating children of any age? And we'll be talking a bit about the paper published recently using data from the Zoe COVID study contributions that you gave us, looking at these long duration symptoms of COVID in children. And there's no better people to discuss it than all of us, because we're all authors on the paper, so we should know about it. So let's jump straight in to topic number one. Can children get serious COVID, and does it really matter in cases? And really the first thing, let's just get ourselves settled here about what are the case numbers looking like in children, and why are they what they are. And so you can see here this graph where we've, this is from the Zoe study, where we've divided age groups over the last couple of months. You can see the changes. And what we saw early on was this big peak driven by the 18 to 35-year-olds in that brown was the main driver, but that's come down a fair bit. And you can see the next big one that's stayed fairly high and is peaking up again now is kids under age 18. So that's where we are now. And we can discuss reasons for it, but I think it shows how important it is to discuss COVID in children, because they're fast becoming the leading number of cases in the country. According to our estimates, 14,000 children a day are coming down with COVID, and that rate is, we've seen it go up even faster in places like Scotland, where schools have gone back. So that's the context. Let's get to our first question. And this is, many people ask this, what are the most common symptoms in children? Michael, do you want to take this one, or Emma?
I was going to say that the most common symptoms were actually asymptomatic, that actually on average, if people get SARS-CoV-2, somewhere between 40% and 70% of kids don't have any symptoms at all. But in the study that Michael and I have just done for people who did have symptoms, the most common were fever and headache. And then it varied a little bit according to whether you were looking at older kids or younger kids, as to whether the next things were persistent cough, sore throat and so forth. Interestingly, in younger kids, tummy pain, abdominal pain was a really common symptom, and that did occur in older kids, but not so often. Michael,
so how do people tell the difference between that and just any normal virus?
That's a really good question. And this was one of the things that we did in the study, was that we looked at people who had tested and were positive for COVID, as opposed to children who were symptomatic, tested and were negative for COVID, because there is this overlap between symptoms. And really we didn't see, we did show in the paper what the difference was in the profiles. I think the biggest difference that we saw was in length of illness, which is that on average, children who had confirmed COVID had illness of around 6 days, whereas the kids who were sick with other things, on average, their illness was only 3 days. But there were some differences between them, but really there's a lot of overlap. And I think you highlight the fact that not every snuffly nose is COVID.
So this is going to be a bit of a problem, because it's also in vaccinated adults, we're seeing very similar symptoms at the moment, aren't we? So this headache, runny nose, sore throat are the sort of top 3 in adults who have been vaccinated. So it's going to be interesting.
Well, I couldn't agree with you more. And in fact, as you know, we have a paper currently submitted that compares the symptoms people get after vaccination with symptoms of early COVID. And not even with machine learning or any clinical algorithms, we could not actually tell the difference in that first week after vaccination as to whether people had post-vaccination effects or early COVID. So your comment is absolutely spot on.
Okay.
A little bit different.
Michael, give us an idea of how many children are hospitalized compared to adults.
I mean, one of the very few kind of positive things about COVID is the risk in children is incredibly small. It's not zero. It's important to note that, and nothing around COVID is zero. In the second wave, hospital admissions were around 100 to 400 per million. And the third wave is looking roughly the same. Rates of admission, given also similar case numbers. And as Emma said, the case numbers, and you said, Tim, are relatively high in young people and children just at the minute. And if you compare that to what we're busy with, children's hospitals are incredibly busy. We're not busy with COVID. We're busy with lots of other viruses, particularly RSV. We're busy with other things, other admissions, catching up with elective care and around increasing kind of mental health conditions that sometimes require admissions, eating disorders, tics. So COVID forms a very small proportion of our work. Nevertheless, it's kind of it's there.
So so how many cases would have it in the hospital at the moment? I mean, is it just 2 or 3 people, or is it 20 or 30?
It's in small numbers. We haven't quite seen the peak yet of the PIMS-DS. That's the term that you would have seen in the news, pediatric inflammatory multisystem disorder. That usually comes about 4 to 5 weeks after the peak of infections. So in the first wave, we saw nationally about 300 to 400 cases. We're not seeing it as much yet in Delta. We're not sure why. It may come. We haven't seen that as much yet. So yeah. And
do you think if cases triple, for example, in the next month, are the resources around the country able to cope with that?
I mean, cases are already pretty high at the minute in children and young people. The ONS showed cases around 1 in 30 to 1 in 50 children, young people. So they're relatively high. We're still not seeing kind of lots of admissions yet. So yeah.
Okay. So I guess if we extrapolate, if we're seeing 14,000 a day with symptoms, if it's about 2 per 1,000, you know, we might be seeing across about 20 or 30 kids admitted a day.
That's about right.
Across the country at the moment, and it's going to go up a little bit, but nothing into the thousands or anything that should be worrying. So just put it in perspective for people. It's still very, very unlikely that if your kid does get COVID, they're going to end up in hospital. Okay. And one from Slido here. What damage? What sort of lasting damage is COVID likely to do a child? Are there any, you know, what's the sort of worst case scenarios, I guess people are saying? Do most of them clear up completely, or are some left with problems?
So most of the children that do get admitted, thankfully, have a very good recovery. We're about to publish our post-PIMS-DS work to show that children have a good recovery from hospital admissions. I mean, sadly, in the first year of the pandemic, 24 children sadly passed away. A lot of those children had neurological underlying comorbidities, and the ones that get severely ill tend to have neurological comorbidities. Hence, the JCVI's recommendation to vaccinate that age group post 15 with those. but the majority make a very good recovery, even after hospital admissions. And that's not even looking at community-acquired COVID, which we'll go on to later, who also tend to make a very good recovery and very good reassuring data from our Zoe King's app.
So a lot of kids have asthma, don't they? Which may go away later in life, but I know parents are worried about asthma because that's a problem in adults. Is it the same worry in kids or not?
So we worried about that too in the beginning, and it's absolutely. I'm a parent myself. We've all worried about it. However, that's not what materialized. Children with asthma were more affected with other viruses. So what we're facing now with RSV, and if influenza comes back later on, that will be a concern. Other kind of viruses can trigger asthma, but we haven't seen that as much with COVID. So it's not one of the factors that we worry about. It's mainly the neurological conditions, the severe, profound learning disabilities, young people with Down syndrome. They're the at-risk groups, and obviously immunosuppression.
And are the treatments for kids very different to adults? I don't know, either you or Emma want to take that.
I was just going to come back about the asthma point, because sometimes people worry about whether the duration of illness might be longer in the children who had asthma compared to the other children who didn't have asthma. And I was just going to say, we did actually look at that very specifically, and there really was not any suggestion that that was the case. About 13% of the children who had long illness duration had asthma, and that compared to about 11.5% of the kids who had shorter disease. So, and that was not significant. So whether one has asthma or not did not really affect how long children were unwell if they became symptomatic with COVID.
Okay, well that's reassuring, I think, for lots of parents about the asthma question, which I think we were all very worried about. That was a broader question about, are treatments for kids any different than for adults, really? So I don't know, Michael, do you want to take that, because you actually treat some of these kids yourself?
Yeah, so I mean, in hospital, it's kind of the supportive treatments. With PIMS, which is the inflammatory one, there are different treatments, particularly intravenous steroids or immunoglobulin, and then supporting the inflammatory episode. And but post hospital, it's mainly around ensuring the recovery and getting back into school and supporting the rehabilitation. So children should be in schools. That's where they spend the majority of their time, both physically, socially learning. They get a lot of emotional well-being and physical support. So a lot of the work actually goes into linking in with the community and schools. It's one of the main jobs of pediatricians. We're constantly talking to school staff, constantly working with them. And it has to be said, the education staff have done an incredible job throughout this pandemic. But we'll come to that later. But yeah, it's about making sure children find their own route to recovery.
Okay.
Could I just come back, Michael? Because I was just going to say, I think many parents also think that school is the place for children, for people who've been homeschooling over the last year, I think. And the other thing I just wanted to say was, I'm just wondering if you could give people a feel, although this post-inflammatory multisystem disorder one can see in children, it can be really serious. It's also quite rare. And I'm just wondering if you can give a feel for that, because you've referred to it a couple of times so far, just to give people an idea about how common this is.
Yeah, and also, Michael, if you talk, and is that different to Kawasaki syndrome that everyone was talking about in the first wave and not really recently?
Yeah, it's very different. It's very rare, Emma. You're quite right. In the first wave, we saw about 400 cases, and it was a new condition, and particularly within Evelina and King's College London. We're one of the first to recognize it and describe it. And initially, it looked a bit like Kawasaki. So that means children had a persistent fever, they had a widespread rash. The parents were kind of spot on. They weren't quite themselves, they're a bit drowsy. Abdominal pain and vomiting was a frequent feature. The blood pressure kind of drop was also a very common feature in terms of needing to support the heart. We very quickly figured out as a team, I say the royal we, figured out how to treat it. And now the outcomes are really good, recognize it early, but it's still incredibly rare. I mean, 400 in the first wave and similarly 400 in the second wave.
And that's across all of the UK. That's the whole of UK.
Whole of the UK. We're not seeing as many in this third wave. We may see a few more cases come up because it usually happens 5 to 6 weeks after the peak. Incredibly rare. Very good treatments now, and doctors are well aware of it now if a young person presents to A&E. So very different to the first wave.
Okay, a short question for both of you, because otherwise it's a whole session on its own, is from parents saying, what precautions should we reasonably be taking for toddlers who are hard to control at the best of times, and parents are finding it hard to balance, you know, their social needs, development with disease prevention? Do you think they can reasonably, you know, what advice, practical advice could you give without messing up their education and development?
I think, Tim, we're actually thinking about this particular question with the pregnancy study, which you know that we're hoping to launch very shortly, because one of the benefits of having a well-vaccinated community and having parents vaccinated and having pregnant women and women who've recently given birth vaccinated is that the more our community is vaccinated, the more comfortable people are going to be taking toddlers out, because the prevalence in the community will drop. So I think I know that this might seem sort of a little bit off target, but one of the most important things that we can do to help toddlers is to get everybody else vaccinated, because that will make it safer for everybody. And that's particularly true for parents of young children and women who are pregnant or planning to become pregnant or have recently been pregnant. It's really important, and breastfeeding mothers as well, because if they are vaccinated, their chance of bringing it home and giving it to their child obviously goes down substantially.
Okay, well, that point taken, I think we would agree on that. But Michael, are there any easy tips you might give that wouldn't upset children's development? Do you think we should be washing their hands all the time, or is that impossible in a toddler?
I think basic hygiene is always good, and you'd be surprised what toddlers will learn by imitating and by copying and making it fun. The main thing with children learn through play, and they learn by observing and by watching. So making it fun, chatting, and toddlers look at their parental facial expressions, other people's facial expressions, which is why it's quite important for them to kind of see other adults and how they respond. So it's yeah, I mean,
make it part of playtime and make it fun.
Yeah, exactly. That's right.
All right. Let's move on to topic 2 now, which is all about whether, and a lot of people have asked this question really, including Alberto, are children at risk of so-called long COVID? And maybe we can get Emma to start this off, because you can talk about the study we did and give us some idea of the prevalence on it, and whether that was, you think, a right estimate, or, as some people think, an underestimate.
So thank you very much, Tim. So I know that there are many people who are watching today who've been watching very diligently right the way through. So I really enjoyed talking through the paper in great depth while you were on holidays. And so everybody who has watched before knows everything that I'm about to say. So the answer is, if you're looking at prolonged duration of symptoms, around 4.5% of children who have symptomatic disease will have symptoms that last for 4 weeks. But if you go out to 8 weeks, it's already down to well less than 2%, around 1.5%. So if you come back to the point that we said right at the beginning about symptomatic versus unsymptomatic, our study looked at children who were symptomatic where the start of symptoms could be tied to when their test occurred, so that we could be confident that their symptoms related specifically to a diagnosis of COVID and not to adenovirus, RSV, rhinovirus, influenza to blah, blah, blah. So that was the prevalence in children who were symptomatic. There really hasn't been any evidence that at the moment, I mean, it's very hard to talk about prolonged illness duration if people don't have duration at all at the beginning. And what is certainly true both from our study, and I know that there's some preliminary data coming out from the CLOC study as well, is that some children who have symptoms, people get sick for other reasons other than just COVID. And so I think this is a really important thing. I mentioned already that we looked at those kids who were ill with other things. The proportion of children who were ill with other things that went on to have symptoms at 4 weeks and 8 weeks was less than those children who were sick with COVID. But, and this is really important, those kids who were sick at 4 weeks for other illness actually had a much more burdensome course. They had a much higher burden of disease at day 28. So, and this was to make the point, this is not a competition, but it's to make the point that children who are sick with other things can be quite sick, and they can have quite long-lasting symptoms from other things as well. So can they get long illness? Yes, they can, but it's not very common, and it usually gets better with time. And Michael, I know, has been working in clinics, and we got a lot of feedback that this was the lived experience of people who were working and in these kids with children. And perhaps Michael might like to talk further about the clinical response to our paper and how it fits with what's actually on the ground.
Yes, I mean, on the ground, speaking to colleagues who are kind of setting up some clinics to support children and families around thinking about long COVID. Initially, it was mainly advisory, so supporting pediatricians and others. And it reflected, what we're seeing. It's a very relatively small proportion of our work, but it does make you reflect about other respiratory illnesses, and we've long known that they can cause persistent symptoms. And the main thing is about listening to what the symptom is, and then finding kind of the route to recovery towards that in the middle of a pandemic when there's been so much disruption and other things going on. But including other services, well-being services, mental health, community services, there's been a lot of pausing of those services and the need to catch up with other things. So it's about putting everything in context and in perspective, really. Okay,
so anyway, we think it's some of the order about 1% is roughly where it is.
At about 8 weeks.
1 in 70, yep. 1 in 100 kids.
But that is kids who are symptomatic. And if half of the kids are asymptomatic, you could halve that frequency.
Point taken.
With the assumption that they don't go on.
And Emma, has Delta variant changed these stats? Because those data were based on the Alpha variant, really, weren't they? So people are worried that the Delta might be worse and might cause more problems. Have you got any insight?
I do. And I can
tell
you on the podcast that Tim doesn't know about this yet, because I haven't shared this data with him, because it's just this week that we've been able to have a look at this. So when we were having a look at it, if you like, the headline things, which is what's different between them, it looks like with Delta, there may be a little bit more fever and headache, a little bit more smell changes and sore throat, but less tummy pain. But if you're looking at burden of illness, the number of symptoms, and if you're looking at how long things last, and this is early analysis, so I don't want anybody, quoting me extensively in the newspaper quite yet, thank you. But if you look at the burden over the course of the illness, there was no difference really between Alpha and Delta. 4 symptoms on the core illness with Alpha, 4 with Delta, and that was true with the one in the littlies, and in the slightly older kids, 5 or 6. And if you looked at duration, 4 days with Alpha, 4 days with Delta in the children, in the littlies, the 5 to 11-year-olds, and in the older kids, 6 with Alpha, 5 for Delta. So there's no suggestion that the symptoms may be a little bit different, but overall, no real difference in duration, no real difference in burden of illness, and no real difference. There may be just a little bit more in the first week, but not over the illness as a whole in terms of symptoms. So actually, at the moment, there are some differences, but it doesn't look to be profound by any means. And
okay, so that's helpful. Really. But it's slightly worrying that the nice thing that, Alpha gave us gastro symptoms in kids, which differentiated it. And now it looks like we're losing that. So it's going to be really hard to tell this from other infections as we get towards winter. I think that's the other point in terms of the symptoms. We're going to need testing to be sure what's going on, I think.
Well, that might be a little bit to do with the age group again. I went to look at diarrhea when you said the word gastro. So if we looked at alpha and we looked at the proportion of littlies, they were more likely to get diarrhea with Delta than they were with Alpha. But with the older children, 11 to 17, there wasn't any significant difference. So it may be that this is good in younger kids, not quite so good if one's looking at older kids. And I'm going down to see if I can comment about abdo pain, and I'll come back to that later if I can find anything.
I mean, nonetheless, the most common symptoms were still headache, fatigue, sore throat, and fever. And that's what you would see in other respiratory illnesses. In older children, it was still loss of smell was the third most common symptom. So it's still, that's a bit more similar to what you would see in adults, but less so with the respiratory symptoms in children generally.
Yeah, and I think that's a really good point, Michael. So I think people need to ask their kids about sense of smell or test them in ways we haven't really been teaching people, you know, and that can be still the major distinguishing factor from other viruses, because they don't do that. So I think some of that you are right, although it would be just worth mentioning that there does look to be anosmia it was certainly reported in our children who were tested and had other things. Anosmia was actually definitely one of the symptoms these kids got. So it's good, but it's not, there are some other viruses that will give you anosmia as well. It's not perfect. Nothing's perfect, Emma.
That is true. That is true.
Okay, all right.
Except a cup of tea. A cup of tea in the morning is definitely perfect.
You'll have to wait for that. Okay, a more general question here for Michael. What's the evidence that contracting a disease in childhood rather than adulthood gives you longer immunity? And I guess this is more of this general question about, you know, if kids get a natural infection from COVID, is that going to give them much longer immunity than the equivalent adult, you know, 10 or 20 years older?
So yes, I mean, there is obviously an immunological kind of theory behind it, and there is some evidence directly from COVID that potentially natural infection could give a broader response. Because the immune response is not just to the spike protein, it will be to the other 28 proteins that are there. And also the immunity will be kind of in the nose as opposed to just systemically by an injection. So, I mean, theoretically, getting it early in childhood could possibly give a broader response. I think the evidence is still kind of building, and every day there's new data. But yeah, that is a consideration.
Okay.
I was just going to say, although the big issue with that, Michael, is making sure that if a child does get it, they don't pass it along to everybody else in the family, because it's a balancing act, that question, that statement.
Yeah,
definitely.
Everything's a balance.
Yeah, definitely. When it comes, we're going to get onto this topic, I think, about vaccines and things in a minute, but the final one in this section, you've sort of answered it for us, Michael, because you mentioned neurodevelopmental conditions, but you didn't specifically say what about things, autism spectrum disorder, ADHD, these sort of more common other mental health disorders, conditions. Any evidence there increased risk or not?
So the increased risk is mainly around severe to profound learning disability. So not everyone with autism or ADHD will have learning difficulties. In autism, the prevalence is around 50%. It's about thinking about the impairment, where the disability is. And it's about particularly children in special schools or have particular learning disabilities, severe ones. And we've seen that in adults, and that extends downwards into children. Children with genetic disorders, particularly Down syndrome, and then other conditions associated with
I find that, I mean, it's fascinating. I don't understand why. Is there a link between learning disabilities and the immune system?
So, I mean, children and young people with severe learning disabilities generally tend to have other medical conditions, usually genetic or other conditions that may impact response to kind of infection, but also they're a group that are tend to be kind of present late medically, and from increasing kind of socioeconomic kind of deprivation, and other kind of lack of kind of medical care compared to other children. So,
okay.
So
it could be a marker of other things rather than the actual problem itself. Okay.
Correct.
Okay, let's move on to the vexed subject of should children be getting vaccinated, which I think always depends on the context. So I think we have to be looking like now rather than in theory ever. And so if we phrase that in the current environment, which is of 75% of adults having been vaccinated, but rates of cases, hospitalization, deaths going up, children going back to school, problems with education, all this. So the first question is, what sort of data do we have about safety of vaccines in children? Who wants to answer that one?
Well, I'm going to actually answer. One of the things I'm going to just say is that, as people know, currently 16 and 17-year-olds can be vaccinated, and children who are younger than that with significant other medical comorbidities, or who live with other people who've got other comorbidities. So in terms of the lived experience of the community, actually about 40%, actually no, it's more than that. It's somewhere around 40% of 16 to 17-year-olds have been vaccinated. So the first 4 weeks of vaccination in the United Kingdom of children will fall due next Tuesday. And so we are set up ready to have a look and see what the vaccination profile of children has been, and then to compare that with younger adults. And we're thinking sort of somewhere around 18 to 25 would be a reasonable group to have a think about. So if you're so in terms of what's the experience, what's our experience of what vaccination has looked like in kids, we are gearing up to do it as soon as we've got 4 weeks of data. With respect to trial data, I might come back and ask Michael to have an answer about that. My understanding is that with respect to this, the benefits well outweigh any potential risks to the child, but Michael might want to put some parameters around that statement.
And talk about maybe the US experience as well, Michael. Be aware they've been, in some states at least, they've been quite aggressive about doing the 12 to 18-year-olds.
Yeah, I think every country context is also different, Tim, and data comes in daily and weekly. So I think the first thing to say about vaccinations is in the UK, the take-up's been brilliant. Public Health England have just announced that it's prevented 100,000 deaths in adults. But what we do know is that the risk exponentially increases with age. That's one of the things we know about COVID. And we've already said the risk in children is incredibly low. And one of the arguments about vaccinating children early on was it was going to help protect adults. And that's kind of gone away with Delta a bit, because it doesn't stop transmission in children. And hence the benefit towards adults is mainly by vaccinating adults. So it mainly comes down to what's the benefit risk towards vaccinating children. And that's something everybody will have an opinion on. I have to say, I've been completely trusting the JCVI, and I know quite a few of them, and a lot of them are on-the-ground clinicians and international.
This is the Joint Committee of
Joint Committee of Vaccination and Immunization.
Yep.
The one thing to say about the UK, it's important to have public confidence in vaccines. We're going to need vaccines for a long, long time, the rest of our lives and our children's lives. So the safety has to be really robust. The safety data has to be really, really robust. It's not just about efficacy. And the concern here is about the only vaccine available now is Pfizer. Hopefully other vaccines are available later that are less reactogenic. At the minute, we only have Pfizer. And the concern is myocarditis.
This is for kids, Michael. This is because we've always got the other ones for adults.
This is all about children. And the risk of myocarditis increases with decreasing age.
Just explain what myocarditis is, Michael.
So that's inflammation of the heart. It could, in about half of children reported in America with myocarditis, they required hospital admission. None
Do
of
you
them
put a figure around that, Michael? Roughly how many cases per 1,000 kids vaccinated?
The latest from the CDC is about 1 in 20,000. We're still waiting for more detail. The risk is mainly with the second dose, which is why the JCVI has said we're waiting for the second dose for 16 to 17-year-olds until we see a bit more data. And the risk is mainly in males. So the risk in males is 6 times that of females. And the risk for the second dose is about 6 times that of the first dose. So it's about 1 in 20,000, and in males it's roughly about 1 in 6,000.
This is in children, because it's
children.
Okay, so I'm interested, I'll be very interested to see whether that's little children or big children, given that puberty is really the point at which you start to see certainly hormonal differences starting to differentiate out between children. And that's really, you know, about 9 is about the time when most children start to start.
So they've only looked at the 12 to 18. The clinical trials in younger children are ongoing. But again, looking at safety data, it's mainly post giving large amounts of vaccines to children before looking at safety signals as opposed to just the clinical trial data.
Michael, can I ask you just to contemplate, one of the things that we've talked about before is that children are often immunised against flu, even though their risk of dying against flu is low, but it's because it's important to minimise community transmission generally. And it's always this balance really between the benefit for the community against the risk for the individual with any vaccine. And certainly with flu, that's a risk where the balance has come down in favour of vaccination because it's of so much public good overall. Where do you, I mean, I know you're saying at the moment you're waiting to watch and see. Do you think we're going to have a similar argument with respect to COVID?
I generally think that the data of COVID in terms of vaccinating children to provide a wider community just isn't there because it won't block transmission. The vaccines are incredibly efficacious in adults. So just vaccinate the adults and the take-up has been incredibly high. The efficacy in COVID vaccine is very different to flu vaccines, which changes. And with flu, it's different. It's an intranasal vaccine. It's got very good safety. And children are very infectious, young children with flu. And the susceptibility in younger children is very different with COVID compared to flu. So it's not flu, it's not measles either. So
if I can summarize, Michael, your view, it sounds like you're, at the moment, you don't have sufficient evidence, you're saying, to go ahead and vaccinate all kids. So that's a great idea. You seem to be slightly on the fence. And in a way, you know, the older the kid, the more likely it is they're going to benefit from it, and the younger, the less likely. Would that be summing it up?
Yeah, and particularly those who are kind of with disability and immunosuppression, 12 to 15, it's right that they get it. And 16, 17-year-olds having their first dose. But yeah, and again, it might change next week, and that with more data, with different vaccines, we'll just have to wait and watch, really. The other point I want to add is the ONS antibody data showed that 16 to 17-year-olds on the 26th of July, about a half to 2/3 had antibodies already. So that's quite high. A lot of 16 to 17-year-olds have already had the infection before the vaccination. That's probably going to be a bit lower in younger children. It's not going to be a lot lower, but it will drop a bit more. So the secondary school antibody survey from PHE show, and that's in the beginning of July, was about 40% of secondary school kids in England had antibodies. Now those levels will rise because we still have, in the summer, we've had high infection rates. So by September, those rates will be higher.
So if you had kids at school, would you want their antibodies to be tested before giving them a vaccine?
I think logistically that's a big undertaking, and it is.
No, I'm asking you personally. I'm asking you personally if you could do it. That's all.
What would you do with the result? What would you do with the result? How would it change what your decision was?
Well, I wouldn't vaccinate someone who had evidence of a recent infection. I think that would be foolhardy, really. And I think because what we're realizing is that vaccines are a finite resource. And at the moment, I've been talking all week about the rise in hospitalizations in adults and waning of the vaccine in adults. And so we're talking about having to reserve vaccines for boosters before the end of the year. And we may not be able to do all kids and give boosters to elderly and healthcare workers unless we start selecting people by need. And basically, a kid who's recently had an infection, whether it's clinical or by antibody, probably doesn't need a vaccine shot, is my view. So it's a more complicated model than we had, I think, just getting every adult done.
I think you're absolutely right, Tim. I think this point that you're making is that it has to be a nuanced discussion, and it's a temporal discussion according to circumstance, and that the decision that we might discuss on Monday versus Thursday last week versus Friday in 2 weeks' time, these are fluid decisions that are being made with the best information you've got at the time, but that information is varying.
Yeah, and
I think I was just going to say the other thing about immunizations. I always talk about other conditions and other diseases. I know this about COVID, but school-based immunizations in year 9 and year 8 have dropped by 20%. And these are for diseases that really affect children: tetanus, diphtheria, polio, meningococcal bacteria, 4 strains, that's A, C, W, Y. There's a big catch-up that needs to happen there. MMR has dropped by 2%, and that's a really important vaccine. It might seem small, but it's very important. Plus, we're going to be extending the flu vaccination all the way up to year 7. It used to be in younger children. So there's still a lot of vaccinating kids that needs to happen, and a lot of resourcing.
Yeah, and I think this point about measles is actually really important. About a year and a half ago, I looked at the measles rates in England, and we'd dropped out of the measles vaccination rates in the UK had fallen so low that there were resurgences of infection, and England was no longer regarded in the top tier of vaccinated countries around the world, which, considering that we are a relatively wealthy country, is a real indictment on, and something we have to pay a lot of attention to get measles vaccination rates back up to acceptable community levels to stop transmission in kids.
Right, I'm going to give you just some quick answers. I'm going to pin you guys down. So if you were in charge of the system, what age would you, and you had unlimited resources, okay, unlimited vaccines you've got to get rid of, they're all going to be thrown away if you don't use them. At what age would you be vaccinating children down to who didn't have contraindications? Emma, do you want to go first? Quick answer.
At this point, I'd say high school.
And give us an age for your high school.
12.
Michael?
Again, can I just add another side note? I think one of the main things is we need to be vaccinating adults. We can't forget about the global situation. Absolutely,
you've got to vaccinate the adults as well.
And if we're not vaccinating adults in other countries, the pandemic is going to carry on. And we only have a few months left, because by the time everyone gets infected and everyone sorts out the IP and the logistics, time would have gone. So my view is get the vulnerable vaccinated, and not to think about a single country vulnerable, a whole globe vulnerable. And then let's think that's a better answer than mine. Sorry.
Yeah. I think that's a better answer than mine. A better answer of mine is that we take a world view. So I retract my comment, Tim. In England, if I was looking, and Scotland and Wales and Northern Ireland, if I was doing it, I'd still give the same answer. But if I was looking at a global view.
Yeah, okay. Well, I'm still going to pin Michael down. Is there an age at which you think it's really too young to give kids a vaccine? Would you give a 2-year-old a vaccine, for example?
And we do give 2-year-olds vaccines. If it's got long-term good efficacy and very good safety, then we do that already. However, if the illness is, unless we have kind of new variants that are affecting children differently, that might change the answer again. But at the minute, we know that children, thankfully, are very spared, particularly the younger children, and hence you wouldn't go down to that age now, certainly not.
But I also just,
where would you go? Are you in agreement with Emma? Do you think the sort of decisions get tougher below the age of 12?
Certainly. I mean, before below the age of 12, it gets incredibly hard. It depends, again, what vaccines are available and their safety. I think that's crucial. Safety is the number one consideration here.
Okay, all right. I pushed you hard enough. I'm not going to get more out of you, I can tell. Okay, let's talk about, we haven't talked about rashes, and a lot of people do have noticed and taken their kids to dermatologists, because my wife's a dermatologist, with strange rashes, and this is often the first way they've worked out that actually they had COVID several weeks before. Does anyone have any evidence that vaccines can cause these rashes in kids, or get shingles after it? Do you know? Have you seen
this? Is a really funny question, because I talked to my friends from school and from university on the phone and with WhatsApp and things. And one of my friends took a picture of her husband's toes when he got post-vaccination vasculitis and sent me this photograph 12,000 miles away to say, I think it's insect bites. And I'm saying, I don't think it's insect bites. I think you need to go to hospital and have them look at this and have this documented. So to come back to the thing, do people get sort of these sorts of COVID toes? So certainly we see this in adults, and we've also seen some post-vaccination responses in adults. Michael, can I ask you to talk about what's seen on the ground in kidlets?
Again, viruses very, very commonly, and particularly in children, cause rashes. Is one of the most common thing of viral rash, and sometimes it's hard to know what virus it is. Obviously, if it's accompanied by the other symptoms, and then it might make you think a bit more, but it's very non-specific.
Okay, all right, let's move on. So back to school. Scotland, kids have already gone back to school, and this is all going to happen this week in the rest of the UK. We've seen Scottish rates go up in the last week quite dramatically. First, I think we're all expecting rates to go up. There's no reason they're not going to. I can't see anyone not agreeing with that. But a question from Slido is, do you think, in the light of the new environment, the Department of Education's advice is actually adequate, and getting rid of these bubbles, is that a good idea now? Is that time gone? Was it ever effective? Michael, do you want to start us off?
Yes, just to go back to one of the main harms that have happened to children have not been directly from COVID, it's been indirectly. And I think it's right that children are being isolated. Having multiple repeated isolations of 10 days to 2 weeks is particularly harmful for many, many different reasons. Missed therapies, missed education, even the anticipatory anxiety of knowing you'll be isolated soon has been quite harmful for kids. We've seen definitely, as pediatricians, a rise in mental health conditions, and it's affected those with disability, special educational needs in deprived communities a lot more than the well-off, the middle classes. So yes, I agree with not isolating children. All secondary schools will require in-school testing twice between 3 to 5 days in the first week. So all children are going to have to be tested. Inevitably, a lot of those will need isolation, sadly. And then it will be twice weekly testing. I'm hoping going forward, we'll move towards a clinically informed testing as opposed to just asymptomatic testing. So testing children who are unwell with symptoms, and then they stay at home if they're not well.
So will this lead to less exclusions, the new policy, do you think?
Absolutely, yes. The testing policy has changed and the isolation policy has changed, which means kids don't have to isolate unless they're identified as a very close contact, and then they'll be recommended to have a PCR test. Obviously, if that's positive, you isolate.
Yeah, no, but not everyone has to isolate who's been contacted. So it's a bit like the pingdemic, that we were seeing this actually, but if you didn't have symptoms, your chances of having the infection were tiny, and really was a waste of time being isolated. So hopefully they've learned from the adult experience and not damage kids' education.
I mean, I think one of the things that you're really referring to here, Michael, is that I think if I'm misquoting you, please put me right. I think you're saying that you think that this is going to be endemic and we're just going to accept that there's going to be reservoirs of infection, particularly in children. If all of the adults are vaccinated, where is it going to be? It's going to be coming in from different countries, or it'll be coming from children being a circulating pool. And you'd be happy to live with that as long as all the adults were vaccinated. Is that a fair representation of your view here, or is that an unfair representation?
I think it's hard. I think happy to live with it isn't. I mean, I would love for it to magically disappear. I know it won't.
Acceptance of a balance.
Okay, yeah. There's a few worried teachers out there now, and one of them's asked, I've got asthma, I'm 66 years old, you're saying, we're just going to carry on. Should I be wearing a mask? What other advice, should they have? Should they be worried? This
comes to this issue that children don't get sick, but children go home to mum and dad and aunties and grandmas and the ladies down the road and the gentleman who lives over the street and their teachers. And so this is a really important question. And for the lady who's got the asthma and who's 66 and vaccinated, I suppose coming to the mask in the classroom, is it just this person wearing the mask? In fact, I don't know if it's a male or a woman,
yes.
a man or a woman here, or is it all the children wearing the mask? Because masks do reduce transmission, and there's a really interesting study on this where they put the masks on because in humans masks are accompanied by a whole host of other behaviors, like people tend to distance a bit more, they wash their hands a bit more. It's signaling of a whole other social distancing behaviors. In animals you have the advantage that they don't understand what the mask is there for, so you don't get all of this other behaviours accompany. They're either wearing the mask or they're not wearing the mask, and it does reduce risk of transmission if both people are wearing masks by around 2/3 to 75%. Now that's which is great. But I don't know what I would advise this person at the age of 66 with asthma who's got vaccination. I think it's a really difficult one. I think because they're not going to be putting masks on the kidlets.
No, they are in some countries, interestingly, and some states and whatever. So it does vary around the world. Everyone has a different view on masks, and we've taken a rather anti-mask view in this country for various reasons. But I don't think anyone knows the real answer. But I think it's down to personal choice, and I think a lot of people will feel safer still wearing a mask if they want to. Whilst rates are high, and the context is very important. If rates 1 in 100 people have COVID, I think wearing a mask is important. If it's 1 in 10,000, it's a different story. It's a different story, exactly. Okay, so I think we've covered. Is there anything else either of you want to say about how schools and parents should adapt to live with COVID in this new context? Emma.
Well, one of the things I was going to say is I think this comes back to something that Michael said as an indirect consequence of the pandemic. I think that for most adults, this has been one of the more frightening and distressing times of our lives, that this new thing has arrived and we've had to adapt quickly, change around the world, distancing, not being able to see family and friends. And in adults, this has been, it's been very tough. I can't imagine how much harder that would be if you were 5 years old, and particularly if you've had members of your family sick and in hospital, or have potentially lost members of your family, particularly older members of your family. So what I would say is I think that Michael was talking about this in terms of indirect fallout, that in many senses, I think that the biggest effect of the pandemic on children has been indirect fallout. I've got kids, and my kids are now out of school, but my daughter couldn't take up a job easily when she first arrived. She ultimately found a job with a wonderful department to help with COVID, which was terrific. But she'd hoped to go travelling. That didn't happen. My children can't go and see their grandparents. And their grandparents can't go to see them. They've not been able to sing in choirs. They've not been able to be involved in dance groups or go out with their mates or go on adventures. All of that normal activity that would have happened for my family in that sort of, you know, young adult behavior, all of that got curtailed. And I think it's been much harder socially for those of us who are fortunate enough to be in, you know, to have a long-term relationship that's happy, which I know has not been the case for everybody, who've been in employment, who have not lost their job, who have got enough money to pay the bills and put a roof over their head and food on the table. It's not been good. But for people who have lost so much more, not being able to do exams, not being able to go to class, not being able to have their GCSEs, not to have their proper A levels, not being able to participate in university in first years and second years, or not being able to get into the workplace because the opportunities for people at those young ages was so much more curtailed than it was for older people. I think the indirect burden of the pandemic has been greater for those people than for many middle-aged adults who didn't get sick.
Thank you. Okay, so it's a call really for schools and parents to acknowledge that and try and redress some of that lost time and fun also. Michael, anything to add to that? What you would advise parents and schools?
Yeah, I would echo kind of what Emma said. And just to say that I work with education staff and therapists that go into schools. The government have only funded 1.4 billion out of the what the educations are, the Education Policy Institute asked for, which is 15 billion to catch up emotional, social learning, recovery for children, to properly invest in schools and buildings and improving ventilation, which will help everything, not just kind of COVID. And that hasn't happened. So it's put people in a tough situation. And who it affects is not only children, it affects those who are living in deprived communities and children with special educational needs, which affects about 15% of kids. They're the ones that have been hit hardest in the pandemic. And I'm just hoping that policymakers will just think about that in terms of the future generation. And that's how you improve health in generally, by looking at those inequalities. It's not just thinking about one virus.
Absolutely, yeah, well said. Okay, so I think we're going to wrap up now. Hopefully, thank you very much, Emma and Michael, for joining us. Thanks everyone for joining us. Fantastic questions. I think we've got an idea of the scope and problems in kids. Most of your children have an extremely small chance of getting unwell. There is a risk for everybody, but it is much smaller. Hopefully, we've put it in context for you. And really, you know, a call to try and make up that lost time with these kids and do as much as we can for them. Just to remind you that the Zoe COVID study is an essential tool used by the government to help track the epidemic. Please keep logging. The stuff on vaccines is incredibly helpful. It's the only way we're getting this information in the whole world, especially in the kids as well, you're logging for. Got all the useful links which are on the website. Do subscribe to the Zoe on YouTube and Facebook. And thank you again for all your attention. And we'll see you soon with our next webinar. Thank you.